This is Chapter 4, Recording 4, Written Communications and Documentation. I believe I impressed upon you earlier about the importance of documentation. For every contact that we have, whether we transport the patient, whether we're just called, even if we're canceled on the way and we never actually talk to a patient, we will still write a report. Typically, we call these patient care reports or PCRs, can be a pre-hospital care report, run report, trip report. I mean, there's several different things that we call these by, but they are legal documents. It records all care starting at dispatch. So if we get dispatched, even if we don't leave the bay, just being dispatched, we will still have to write a care report. There are two different types of PCRs. There's a written report and an electronic report. I am a huge proponent for written reports. However, the national scene does not agree with me. All services have gone to some sort of electronic report because of insurance purposes. There's several different functions that the PCR serves to do. It serves to continue the continuity of care. Oftentimes, if we're on a severe trauma, the physicians at the hospital, the surgeons will want a copy of our report very quickly so that they can review everything. We are definitely the eyes and ears of the healthcare team because we respond to the scene. We see the patient before we clean them up and get them semi-put back together as best as we can. And so they like to know a lot of that. Car accidents, not only are we going to describe the patient and how we found them, we're going to describe the accident itself, approximate speeds, what condition the car was in, what position the patient was in, if we used safety restraints or they used safety restraints. It really kind of paints the picture for them, and that's what your PCR should do. We use it for legal documentation. Oftentimes we don't make it to court, but we can get subpoenaed. There can be legal action. Our document is very important for that. Education, we use trip reports all the time to identify trends. For education for the community, if we see a huge rash of children getting injured in bicycle accidents and they weren't wearing helmets, typically that spurs public health officials to release a community education program regarding the use of helmets. You'll see every year that there's new material regarding flu vaccinations. That's something that public health does. Once we start seeing spikes in the hospitals and ambulance calls about flu exposure, that prompts them to start putting out that educational material. Administrative information, their essential research records. We used to just decide to do treatment because it seemed logical. Our first protocols were not evidence-based whatsoever. It's like, this sounds like a good idea, let's do that. There were very smart people making those decisions, but they didn't truly have any basis to go on other than their own education and knowledge. What we do now is we continue to look at treatment, how we treat our patients, and then the outcomes of those patients so that we can identify areas that we need to try something different because it's not working. And then we test new and innovative ways to take care of patients to see if that's actually helpful. Your PCR is a part of ongoing research. Even if somebody doesn't pick it up, it has the potential. Evaluation and continuous quality improvement. You will have a quality improvement officer at your service. You may not know exactly who that person is. It may just be the director. But they are constantly reviewing charts to find out where the particular shortfalls are of the ambulance service and how you can improve. If the same person is not necessarily making a mistake, but it's not best practice or they could do something better, oftentimes that will be a situation where the director can talk to them and inform them. Sometimes we just don't know that we're not doing things the best way for our patient. If the service as a whole is struggling, again, opportunity for education. During your next in-service, you may focus on a specific topic because of quality improvement. Following information is collected on the PCR. Now that they're drop-down boxes, click boxes, fill in the blanks, it's a lot easier to make sure you don't forget information. It's not as comprehensive as a written, in my opinion. Again, my opinion. You'll put chief complaint, level of consciousness or mental status, vital signs. When you transport patients, on average, for the majority of your calls, you should be taking at least 2 sets of vitals. You should take one at the scene or shortly at the beginning of transport, and then before you arrive at the hospital, you should take another set of vitals. That depends on the condition of your patient. The more critical your patient is, the more often you should be taking vitals, but every patient should have at least 2 sets of vitals. Your patient demographics, which is like their age, gender, ethnic background, address, or where you picked them up from. Administration information that's gathered on a PCR is the incident, the EMS unit that was notified, and the time that they were notified. Oftentimes when you go en route, that time will be recorded as well because you'll let dispatch know. When you arrive on the scene, sometimes when you make patient contact is also recorded. When you leave the scene to begin transport or when you clear the scene. When you arrive at the receiving facility. Sometimes when the patient care was transferred, kind of depends on your service. And then when you're cleared of the call and ready for service. Types of forms, you have the traditional written form, check boxes, fill in the blank information, and then you just have a huge area to write your narrative. And typically you start with, this is what we were dispatched for, this is what we found at the scene, this is our patient, this is their complaint. You write out all of your assessment tools, even if it's within normal limits. And then you'll go through what you found on physical exam. You'll go through everything the patient told you, everything that you found. Vitals should be in there. Any treatments that you performed, your patient's response to those treatments, why you believe that they have what they have, and then how and when you handed off the patient, and then if you take anything along with them to the hospital, what you did with that. It's a lot of information. Computerized versions tend to be a lot more check boxes and less narrative. Elements of the narrative, I already talked about it. Refusal of care is one that I didn't go through. If your patient refuses care, you need to document the conversation that you had with them about the risks of refusing care. You need to put any statements that they stated regarding the care, and then you need to provide documentation that you counseled them, that if they change their mind, they can call back at any time, that services are still available to them. You want to include significant negative or just significant findings about the scene. Like I said, with the car accident, it's not just the patient, it's the accident itself. If they fall from a height, you want to try and record how high that is. So more details, paint the picture. Don't make judgments about the patient's condition. Avoid radio codes within your report. Only use standard approved abbreviations. Don't make up your own. This is not the time to be creative. Yes, in medicine, we do have approved abbreviations. If you aren't sure or don't quite know what the abbreviation is, always go with plain speak. Remember that the report itself is considered a confidential document. You're not going to share that with anybody that doesn't need to have it. We share it for continuity of care, we share it for quality improvement, and we share it for billing purposes. And legal purposes. That's pretty much it. Reporting errors. If you leave something out, recorded incorrectly, don't try and cover it up. You should be able to see your mistake. So a single line, at the very least your initials, sometimes a date is appropriate, but you should be able to legibly read what you put in that mistake or what you have underneath that line. We don't scribble things out. We sure as heck do not use whiteout or any sort of corrective material, I guess. Falsification results in poor patient care, may result in suspension or legal action. Even if you messed up, document it. If you gave a wrong dose of the patient's medication, you were only supposed to give them 1 tab of nitro and you gave them 5 and bottomed out their blood pressure, document it. Okay? Don't falsify that. Single horizontal line, write the correct information next to it, initial. We don't erase. We don't ever document anything in pencil. Never. You shouldn't even have a pencil in your hands. Any sort of legal important document, even with the things that you're filling out for school, pen. It should all be in pen. And correction fluid. That's what I was trying to think of on that last slide. Documenting refusal of care, it's definitely a common source of lawsuits. If a patient refuses care and they're of sound mind and then something happens to them, they actually have a significant heart attack, they progress into a significant illness, or they die or suffer some sort of lasting effects, it is very often that they themselves or their family members will come back after us for not transporting them. So you need to be extremely thorough in your documentation. Make sure that you document any assessment findings, medical care that was given. Sometimes we do a treat and release. Oftentimes patients that experience low blood sugar, give them a little something to eat, get their blood sugar back up, and they decide they don't want to go to the hospital. We're still going to thoroughly document or dispatch what we found, how we treated the patient, their response, and then their refusal. Have the patient sign a refusal of care form. Every service has one. And then you'll have somebody sign as a witness. Could be a family member, could be a police officer, other personnel at the scene, could be as simply as your partner. Somebody should witness a refusal of care. And then make sure that your PCR is complete so that you don't have any questions if it goes to lawsuit. Special reporting situations. This depends on your local requirements, but you will know if you have your protocols. You should know your protocols very, very well. Gunshot wounds or violent offenses tend to be something that we need to report. Dog bites, some infectious diseases, the CDC tracks that, and so we have to let them know. Suspected physical or sexual abuse, neglect in children as well. Multiple casualty incidences, oftentimes we need help or assistance, so you need to know what's going on there. We will continue on in the next recording.